When you hear blood clot in the leg, what's the first thing that comes to mind? Probably the immediate danger, right? The life-threatening stuff. But what if I told you the real story, the one that can last a lifetime, starts long after that initial crisis is over? That's what we're going to get into today.
Yeah, think about that for a second. What if the biggest danger isn't the clot itself? It kind of turns things on its head, doesn't it? We're so laser-focused on stopping that clot from traveling to the lungs that we often completely miss the permanent damage it leaves behind. And that is the hidden story we're unpacking.
Right, so we're talking about the clot's lingering shadow. Most people, maybe you too, think that once you're on blood thinners, you're in the clear. The danger's past. And look, for the immediate life-threatening risk, that's true. But for up to half of all patients, something else is left behind. A chronic condition that can totally change their quality of life, forever. And this thing has a name. It's called post-thrombotic syndrome, or PTS for short. Now, this isn't a new clot, not at all. It's the wreckage left behind. Imagine this. That original DVT is like a demolition crew for the tiny, one-way valves inside your vein. It just wrecks them, so now the blood can't flow back up to your heart the way it's supposed to. It just pools. The pressure builds and builds in your lower leg. Doctors have a fancy term for it, venous hypertension. But really, it's the root cause of every single problem that's about to come.
And when I say problems, I mean serious problems. This isn't just a minor annoyance. We're talking about chronic, unrelenting pain and swelling. Your skin can literally get tough and change color. Some people get this awful cramping pain, called venous claudication, just from walking. And in the really severe cases, you can get these incredibly painful sores or ulcers that just refuse to heal. This isn't an inconvenience, it's a lifelong burden. It can absolutely steal your quality of life.
Okay, to make all this a little easier to picture, let's use an analogy. It's actually a really good one. Think of your leg vein as a superhighway for your blood. A DVT, well, that's a massive 10-car pileup that just shuts down every single lane. Total gridlock.
And, just like in real life, not all traffic jams are the same, right? A fender bender on a side street is one thing, a complete shutdown of the main interstate is another. In your leg, that main interstate is the iliofemoral vein. When a clot happens there, we call it an IFDVT. It blocks the single main route for blood trying to get out of the leg. And look at this number, it's wild. Patients with these huge clots are more than twice as likely to get the absolute worst forms of PTS. It's a huge, huge deal.
So you're probably asking, okay, so how do we fix this? Well, the standard way we treat these clots has been around for a long time. But, and this is a big but, it has some pretty serious limitations when it comes to stopping that long-term damage.
All right, so the standard treatment is anticoagulation. You know them as blood thinners. And let me be clear, they are amazing at what they do. They stop that clot from getting any bigger, they prevent new ones from popping up, and this is the big one, they slash the risk of a piece breaking off and going to your lungs. But now look at the other side of the chart. What don't they do? They don't actually get rid of the clot that's already there. They don't fix those busted valves. To go back to our analogy, blood thinners are like the police setting up a roadblock to stop more cars from joining the pileup. That's great, but they don't actually call in the tow trucks to clear the wreckage. The traffic jam, it's still there.
And that brings us to a really obvious question, right? If the leftover clot, the wreckage, is what's causing all this long-term damage, why on earth don't we just, get rid of it?
Exactly, right? If the blood thinners just stop the jam from getting worse, why not just call in the tow trucks and clear the road? It seems so simple, so logical. And that simple idea is what's behind a whole different, more proactive way of thinking about these really bad DVTs. The whole point is to get the blood flowing again and stop that highway from getting permanently damaged.
And it turns out, there are a few ways to be that tow truck. Doctors can thread these tiny little tubes, or catheters, right up to the clot and just drip powerful clot-busting drugs right onto it. Or they can use these cool mechanical devices that they grind up and suck out the clot. There's even a way to go in and surgically remove it. The goal for all of them is the same though. Get that vein open, get it flowing, and do it fast.
Okay, so this proactive approach, it just makes sense on paper, right? But does it actually work in the real world? Does clearing out that clot really prevent post-thrombotic syndrome? Well, for that, we can't just rely on logic. We've got to look at the hard science, at the big clinical trials.
And when it comes to this question, there's one study that's the big one, the main event. It's called the ATTRACT trial. This thing was huge. They looked at almost 700 patients. They split them into two groups. Half got the standard treatment, just blood thinners. The other half got the blood thinners plus one of those proactive clot removal procedures. This was it, the definitive head-to-head showdown.
And when the main results came out, honestly, people were stunned. It was a bit of a letdown. After 2 years, they looked at the overall rate of post-thrombotic syndrome and, get this, there was basically no difference. 47% in the clot removal group still got it, compared to 48% in the standard group. I mean, that's a statistical tie. At first glance, it looked like all that extra effort and risk made no difference at all.
But you know there's a but coming, right? The researchers didn't stop there. They dug a little deeper. They said, okay, what if we only look at the cases of PTS that are really, really bad, the ones that truly ruin your life, the moderate to severe kind? And this is where the story completely flips. Look at this. Suddenly, it's a different picture. Proactively removing that clot did make a difference. It significantly dropped the risk of getting the worst forms of this disease. You see it right there. Only 18% in the proactive group got moderate to severe PTS versus 24% in the standard care group. That's a real difference.
And for those really high-risk patients, the ones with those massive iliofemoral clots we talked about, the benefits were even more obvious. This quote from the trial's analysis says it all. The proactive procedure, it led to less severe PTS, it helped more with the pain and swelling, and, this is so important, it led to a better quality of life. They cleared the traffic jam, and it actually truly mattered in these people's daily lives.
Now we have to be honest here. There is a small trade-off. You can't go in with clot-busting drugs and mechanical tools without some risk. The ATTRACT trial showed that this more aggressive approach did come with a slightly higher risk of major bleeding. You can see the numbers, 1.7% versus just 0.3%. It's a small risk for sure, but it's not zero, and it absolutely has to be part of the decision.
So, where does that leave us? What does all this mean for someone with a DVT today? Well, it means we've thankfully moved past a one-size-fits-all world. The decision about what to do is now way more personalized, as it should be.
So here's kind of the modern way to think about it. First, doctors figure out how bad the clot is. Is it a smaller one lower down in the leg? If so, standard blood thinners are probably going to work great. But if it's one of those big, nasty iliofemoral clots, that massive highway pileup, then it's time for a serious conversation about actually removing that thrombus. And that's a conversation where the doctor and the patient, together, have to weigh the options. They have to balance the very real benefit of avoiding a lifetime of pain against that small but real upfront risk of bleeding.
So if there's one thing to take away from all this, it's this. We now know that not all DVTs are created equal. For the people with the biggest, baddest clots, just stopping it from getting bigger, well, that might not be enough. Taking that extra, proactive step to actually remove the clots can literally be the difference between a full recovery and a lifetime of chronic pain and disability. You know, what this whole story really shows us is how medicine is moving away from just treating a disease name and toward treating a specific patient's version of that disease. It's about using the amazing evidence from trials like ATTRACT to get really nuanced. And that leaves us with a bigger question to chew on, doesn't it? As our medical tools and knowledge get this precise, this personalized, how do we build a system that ensures the right patient gets the right treatment at exactly the right time? That, right there, is the big challenge ahead.